Hello to the few people watching this. My name is Natasha, and I'm going to be talking to you guys today about carnitine deficiency. I do want to note before I get into the presentation that there are a number of different forms of carnitine deficiency, and all of them are extremely rare. Today, I talk about three of the most common forms, but just keep in mind that two of the forms I talk about are also so rare that they don't even have clinical guidelines for how to treat them. And so the data out there on some of these forms is very limited. Here is an overview of what I'll be going through today. These are the SLOs that we know and love and are familiar with. Throughout the semester, we've used these. And so with that, I'm going to be starting with genetic principles. Primary carnitine deficiency is the most common form. There is less than 50,000 cases in the US, making this a rare disorder. Primary carnitine deficiency happens when there is a mutation in what's called the SLC22A5 gene. This presents with variable expressivity in the patients affected, and it has an autosomal recessive inheritance. Here we can also look at the prevalence of 1 in 100,000 overall and 1 in 40,000 in Japan. Penetrance has not been reported on this disorder. Another form of carnitine deficiency is carnitine palmitoyltransferase 2. This happens when there's a mutation in the CP2 gene, and there's only ever been around 300 cases documented, so it's very, very rare. It also has variable expressivity and an autosomal recessive inheritance. An interesting thing about this form that sets it apart from the other forms is that males are more likely to be affected, and there is thought to be some sort of epigenetic or environmental factor, but they're not exactly sure what yet, just because of how rare it is. Third is carnitine acylcarnitine translocase deficiency. This one is a gene mutation that's very similar to primary carnitine deficiency. It's the SLC25A20 gene. There's only been about 103 cases ever documented on this, so even more rare than the previous kind. And as I said, there's certain kinds of carnitine deficiency that are more rare than this. This kind typically causes infant demise. Most infants have cardiomyopathy, just as the prior form, but it's not detected soon enough, and so unfortunately they pass away. This one, just like all other forms of carnitine deficiency, show variable expressivity and an autosomal recessive inheritance. So now we're going to go into the pedigree. As I just mentioned, all forms show autosomal recessive inheritance. However, there has been a few cases of de novo mutations, but they're very rare, and they're still working on figuring out if it really is a de novo mutation or if there's a different condition that has a different inheritance pattern, or perhaps not even a genetic component. So recurrence risk, knowing that it's autosomal recessive, I wanted to ask you, what is the recurrence risk for an affected individual's child? So it is kind of variable, but depending on the partner, most likely the partner is not a carrier, and this can be determined through genetic testing. If the partner is unaffected, then 100% of their children will be affected as carriers. 0% of the children will have the disorder. So for another question, what is the recurrence risk for the parents that have an affected child's future children? And for this, you can kind of use the image on the right to help you. So this is variable, but it's likely around 25%. And if I were to ask you what the variable was, it would be that carrier testing needs to be ordered for the parents. As I mentioned earlier, there are some cases of de novo mutations. So if that were the case, then it'd likely be around population risk rather than 25%. But again, there are certain things about this disorder that have not yet been discovered, so these numbers could change in the future with further testing. So now I'm going to go into disease etiology. First, primary carnitine deficiency. So as mentioned earlier, the first step would be to have a mutation in the SLC22A5 gene. When an individual has a mutation in this gene, they do not produce a protein called OCTN2, and this protein is vital in order to carry carnitine into the cells. When carnitine is not brought into the cells, your body does not process fats into energy. So for the next form, carnitine palmitoyltransferase 2, this one happens when there is first a mutation in the CP2 gene. When this happens, the long chain fatty acids for the mitochondrial matrix for beta oxidation are not entered into the cells. This, just like the previous version, results in fats not being able to be converted into energy. For the third type, carnitine acylcarnitine translocase, this first results when there is a mutation in the SLC25A20 gene. This one is a little bit longer of a pathway because it first inhibits the carnal acylcarnitine protein translocase from being formed. After this happens, it prevents fatty acid oxidation by preventing the transfer of long-chain fatty acid acylcarnitines across the inner mitochondrial membrane. This, just like the other two kinds, prevents fats from being converted into energy. So next, going into the signs and symptoms. Here are the signs of what you are able to see in an individual who likely has carnitine deficiency. Perhaps the most concerning symptom or sign that you will see in an individual is seizures. This is often why many patients seek medical help. Other less concerning signs that you will see with this disorder are muscle weakness, vomiting, hypoglycemia, autism, clumsiness, and confusion. Autism has been linked to carnitine deficiency. However, because of how new it is, it's not always listed as a symptom. However, most individuals who have a form of carnitine deficiency have autism. The exact route of why this happens is still somewhat unknown, but it has something to do with the lack of the body's ability to use fats as energy results in an altered brain function. Another thing to mention is that some of these symptoms might look different in young children than they do in adults. So for someone with hypoglycemia that is not able to communicate their feelings, it might be common to see a child throw a tantrum or a child to do something else that might lead you to think that they're just acting out when in reality it could be something else. Here are what you can't see that will likely be looked at by a physician when seeking diagnosis for this disorder. The first is elevated hepatic transaminase. This can be confirmed by a blood test, and when it's elevated, it's actually a sign of non-alcoholic fatty liver disease. So it can be concerning if too highly elevated. Next is hypoketotic hypoglycemia. This can also be confirmed through normal laboratory testing. Third is encephalopathy. And this can be looked at. It is in the brain, so it would be looked at through something like an MRI. This is what partially is thought to connect autism to this deficiency. Fourth is cardiomyopathy. In the upper right-hand corner of the screen, you can see what a heart looks like with cardiomyopathy. This causes some of the heart problems and cardiac arrest issues that I mentioned earlier with infant demise or simply demise of untreated individuals. Lastly is hepatomegaly. This is an enlarged liver. It is related to the elevated hepatic transaminase. So now going into the diagnosis and treatment. First, with the diagnosis, the first things a physician will likely order with the symptoms mentioned earlier would be an EKG to see how the heart is functioning. Another thing would be serum creatinine kinase concentration. This is to see, well, what is going on with the carnitine. It can see if there's something related to that. Next would be liver transaminase. And often newborn neonatal testing is done for carnitine deficiency in certain states, but carnitine deficiency isn't always detected at a newborn level. So that's why most oftentimes these individuals will not flag positive for carnitine, these types of carnitine deficiencies. However, it should be noted that the only definitive test and the only test that can tell between the different types of carnitine deficiency is molecular genetic testing. On the lower right-hand side of my screen, you can see how molecular genetic testing is typically conducted. This can tell which specific gene mutation an individual has. On the bottom left of the screen, in case you're not already familiar, this is an EKG that will look for heart abnormality. The most common treatment is 100 to 400 milligrams per kilogram per day of an L-carnitine supplement. This is actually something that's easy to get access to. You can actually find it at most grocery stores, which is nice. For those with hypoglycemia, an intravenous dextrose infusion is recommended if hypoglycemia is bad enough. Another thing that can be recommended if the hypoglycemia is not as bad is just frequent meals to balance those episodes. Potassium supplement for muscle cramps are often prescribed, especially for picky toddlers who have this disorder. However, this can also be managed by food. So when we get into the case study later, the individual I talk about eats at least one banana every day and milk to try and up their potassium levels. If a patient does have cardiomyopathy, they will have to see a cardiologist for further evaluation and treatment of that disorder in itself. And then for CACT, medium chain triglyceride supplementations are often prescribed to help with that specific etiology pathway that we talked about earlier. Because of how rare CACT is, there's actually no standard clinical recommendation for treatment. And just as a reminder, CACT is carnitine acylcarnitine translocase deficiency. However, the same can be said for carnitine palmitoyltransferase 2 deficiency. They're both just so rare that there's really no standard for how to treat patients. A lot of the treatment for patients, while it comes with a standardized L-carnitine supplement, it kind of depends on the individual and what specific symptoms they're experiencing. For example, if they're having seizures, then they may be prescribed seizure medication. One thing too that is recommended for all individuals who have carnitine deficiency is a high carbohydrate diet. So without treatment, this is often fatal. And however, when caught early enough, when individuals are put on the L-carnitine supplement prior to these more serious symptoms, they often live full lives without any complications. So going into the more severe cases, when not treated, cardiomyopathy is very common, and this often causes death by cardiac arrest. This is one of the most common causes of death in infants with this disorder because it's simply not caught soon enough, and an infant's heart is very small and cannot necessarily take the impact of cardiomyopathy as long as an adult may be able to. Next is an enlarged liver. This is due to the elevated hepatic transaminase talked about earlier that can cause fatty liver disease. Fourth is many of these individuals can go into a coma because of the effects it has on the brain and also because of extreme hypoglycemic episodes. Fifth is recurrent seizures. If an individual is not being treated for their seizures, they're likely to just continue having them. And this can be dangerous, as I'm sure you're aware of, for many different reasons. You can cause brain damage. An individual can harm themselves during a seizure. And it's just, in general, not a good idea to have unmedicated seizures. Hypoglycemia episodes will continue to happen if a patient is not treating them properly. A lot of times people with hypoglycemia do not realize that it's hypoglycemia, so they may not tie it into their diets and eating more frequently and doing the things that can help with hypoglycemia. So with proper management, these symptoms can be readily avoided majority of the time. When it's in an infant and it's not caught early on, a lot of times it cannot be avoided, unfortunately, which is part of the variable expressivity in this disorder. So finally, going into the case study, we're going to be talking about Finn. And before I get into this, I just want to mention that parts of this are enhanced a little bit to better fit a normal profile of someone with primary carnitine deficiency. A lot of times, because of how rare it is, there's certain things that don't always fit the status quo, but I wanted you listening to this to be able to better understand what it would look like for someone who fits the status quo of this disease, basically. So going into that, Finn is a 2-year-old male who presents to the pediatrician after his mother has an epiphany that she realizes he is having seizures. Some of the symptoms they report are his breath smelling fruity, low weight for his age. They find it very hard to find pants that will fit around his waist but still be long enough for his height. He walks on his toes, and his mom thought that these episodes of Finn waking up in the middle of the night screaming because of how bad his muscle cramps were in his legs were related to his tiptoe walking. Finn has large, uncontrollable mood swings, and oftentimes during these tantrums, he will self-harm himself by banging his head on objects. He has a speech delay and lisp, And he has been recently flagged to possibly have autism. However, because he's only 2 years old, they're still kind of waiting to confirm whether or not this is truly autism or just a normal kid developing maybe a little bit slower than other kids his age. So to tell the story of how Finn was realized to be having seizures. Finn's mom, Tiffany, is a newly graduated nurse. Around his second birthday, she noticed that he would throw tantrums that seemed really over the top. And sometimes after he threw the tantrums, he would all of a sudden stop crying and his eyes would flutter. She assumed this was just because he was finally done throwing the tantrum and finally gave up on throwing himself on the floor and screaming and crying, as many kids do. But the fluttering of the eyes seemed a little bit odd to her. So one day, Finn's dad, Dominic, mentioned on the phone to his mom that Finn was throwing another tantrum, but was doing something a little bit weird. He reported that Finn was laying on his back, not moving, but his eyes were fluttering. Finn's mom had an epiphany during this phone call that her son was having absent seizures, and the years of testing began. Absent seizures are characterized by eye fluttering and temporary paralysis of the body. So after this was discovered, they immediately took him to the pediatrician and they thought that something else might be going on. Since tantrums started around the time he was maybe 14 to 15 months old, and they occur several times a day. To this day, Finn is now 4.5 years old. So, going into the family history, Finn's case does not exactly fit the status quo, but this is his real family history. Finn is the only person in our family known to be affected with this disorder. And that is why he does not exactly fit what is normally seen with this disorder. Pediatricians are still kind of puzzled as why he has a very rare de novo mutation, but they're still working on this with future testing. Physicians were originally led to question if it was carnitine deficiency, specifically because of the possibility of the ketones on his breath by the fruity smell I mentioned earlier. And with the accompanied autism, hypoglycemia, and all the symptoms he were having, they were pretty positive that it was carnitine deficiency. So, first and foremost, the test conducted, he was very first determined to be hypoglycemic and specifically ketotic hypoglycemia based on the ketones that were often smelled on his breath. And this was done with laboratory testing to determine his glucose levels after fasting. Next, after this, physicians were led to believe that it was carnitine deficiency. So his plasma carnitine levels were ordered and were found to be extremely reduced. Third, they ordered genetic testing and confirmed a mutation in the SLC22A5 gene. This means that Finn would be suspected to have primary carnitine deficiency. I do want to note that they're still doing tests to this day. Unfortunately, Nevada does not have very good medical testing when it comes to extremely rare disorders like this one. So his parents often have to travel out of state to California to receive better medical care, which is obviously very hard with 2 children and a dual income working household. So for his projected disease prognosis and treatment, as I mentioned before, autism has been found to be linked in carnitine deficiency in actually most of the individuals who have this disorder. Finn takes 3,000 milligrams of L-carnitine per day. He takes 1,500 in the morning and 1,500 at night before he goes to bed. He also takes a medication to prevent seizures. He is still in the process of further testing to support him with his autism and developmental delays. He is part of a special education program at his school, and here they cater to his developmental deficits, specifically his speech therapy and lisp. So for family counseling, in this image to the right here, Finn has an older brother. His older brother's name is Oliver. Oliver is 6 years old and has been determined to be unaffected. So to ask you some more questions, what are Oliver's chances of being a carrier, knowing that this has an autosomal recessive inheritance? So Oliver's chances of being a carrier are the 2/3 rule, since we know that he is unaffected. What are Oliver's chances of having an affected child, knowing that he has a 2/3 chance of being a carrier? So if Oliver is affected, while there is a 2/3 chance of him being a carrier, affected as a carrier, this is variable depending on who his partner is. If his partner is a carrier, then they would have a 1/4 chance of having a child affected with primary carnitine deficiency, which is 16.67%. I do also want to note that his partner would have to be a carrier of specifically the primary carnitine deficiency mutation. If his partner was a carrier of, say, the carnitine palmitoyltransferase version, then they would not be at the same risk of having an affected child. If his partner is unaffected, then he simply has the chance is of passing it down as a carrier status to some of his children. Thirdly, as a physician, what would you recommend advising Finn's parents, siblings, and children? So, something really vital in autosomal recessive inheritance and really all genetic conditions are carrier testing. So Finn's parents have not yet Finn's parents have been carrier tested, and Finn's brother has been carrier tested, and they have been determined to not be affected. Finn's case, they suspect that he has a de novo mutation. So likely the only people at risk of passing this on are Finn. All of Finn's children have a 100% chance of being carriers. And depending on Finn's future partner, if she was a carrier, then they may also be at risk of having an affected child. Fortunately, because of how rare carnitine deficiency is, there's no fancy foundation specifically for carnitine deficiency, as with some conditions we've seen throughout this course. So our resources are pretty limited, unfortunately. Rareconnect.org was the most specific that I could find for those with carnitine deficiency. They have 2 support groups, one for primary and one for carnitine palmitoyltransferase. GUARD has information about every known form of carnitine deficiency currently out there. Global Genes does not have anything specifically for carnitine deficiency other than that it is included in their list of rare diseases. This is partially because, as I mentioned at the beginning, there's really not much out there for carnitine deficiency, especially the more rare forms. However, they do host various events for individuals with rare conditions to either gather and meet each other, or also they often raise money in support of further research. So that brings me to the end of my presentation. I hope you guys enjoyed learning a little bit about carnitine deficiency. I do want to note the part of our case study that was not completely true is the fact that Finn does not actually have primary carnitine deficiency. He has a form of carnitine deficiency, but they have not yet been able to figure out what specific gene it is. He is the only child in all of the US that has been shown to have this specific gene mutation he has that is still alive at his age, and they are not exactly sure why. His symptoms are being managed well. Thank you for listening.